So today in this video, I'm going to show you the basics of MRI scan, which is ORBIT and PNS. This patient is basically a 24 years old female patient, left-sided orbital cellulitis with periorbital edema and left ptosis. Now, there are two main headings where I'm going to discussing in this video. The very first one is that I'm going to be teaching all the basics of MRI scan for this case, basically. Where whenever there is any orbital invasion or intracranial invasion, how MRI can be useful, the basics of MRI, all the different sections of MRI, T1, T2 and T1 post-contrast, how one can identify all these different sections, what are the basic points in all these scans I'm going to be going through. And the very second part is that while I'm discussing the basic points in the MRI scan, I'll be also talking about the pros and cons of doing a CT scan PNS for patients of this condition. So also I'll be discussing whether or not you should be doing CT scan PNS as an extra investigation for such patients where there is intracranial and intraorbital invasion. Because to be honest, this patient had come to me, she already had an MRI done from outside because she was referred to me by a general physician from outside, and she already had got the MRI done. So whatever MRI I'm showing you is from that particular time. So I did not get the patient a CT scan done, and on the basis of only the MRI which I have right now, I have done the surgery on the patient, and that was a huge success. So I'm going to be talking about basic points as to why MRI alone can be really helpful, and if there is really a need of doing a CT scan only, you can get it done. Otherwise, if you are not able to get the CT scan done, or if you don't feel the need of a CT scan, you can definitely go with just the MRI, and all the points can be covered in the MRI, which you can normally do in the CT scan as well. Now, coming on to the basics of the MRI. So these two main headings will be the hot topic of today's video. So I'm going to cover it everything in basic. So let's begin with the first one, is that the basics of MRI. Now what I'm showing you right now here is the coronal section T1 scan. Now the basic question is how one can identify T1, T2 and post-contrast T1. Also, what are the basic locations one can look for? The very easy method for differentiating T1 and T2 in the coronal scan, axial or sagittal, it is same. It is very simple. Just look for the eyeball. Okay, there are two main locations where you have to look for, is the brain and the eyeball. Now I'm just going to show you this area. I'm going to take it down a little bit and then zoom over here. So before I move on, listen to these 3 points. The very first one, on a T1 scan, the fluid, water or any kind of liquid or secretion will appear as dark on T1, as you can see right now over here, and bright white on T2. Okay, second point is that fat. On T1 scan, fat appears to be as bright white, the same which you can see right now over here. This is the periorbital fascia and the fat in the orbit appearing as bright white on T1. Fat will always look bright white on T1, and on T2 also it appears bright but less as compared to what you can see on T1. The third point is edema, inflammation. Any edema, any inflammation on MRI scan, T1 will appear as dark, and on T2 it will appear as bright white. So always remember that T1 will have a dark edema inflammation, T2 will have a bright edema inflammation. So these 3 points are the basics of your ENT and skull base diagnosis on MRI. So moving on further to differentiate T1 and T2, right? So this is brain and this is the eyeball. So this is T1 for sure because this is not bright, it is dark gray. And also if you keep on going behind and the brain, you have to look for the ventricles, right? So you can see this is a ventricle. So if the ventricle is also bright white, it is T2, and if not, it is dark, it has to be T1. So two basic locations is the eyeball and the brain ventricles. Nowhere else, look nowhere else, you will get confused, because there is one more point of differentiating T1 and T2 just on the basis of the cortex and the parenchyma. That is the gray matter and the white matter of the brain. That is really confusing. You tend to forget that in the long run. So just remember the ventricle and the eyeball for your easy reference. Now coming on to the basics in the T1 right now. So we are going from the front to the posterior part. As it is a coronal section, we are going from anterior, this is the most anterior part, to the posterior part, as you can see, way behind the back of the skull base, up to the basilar artery right here. That's the basilar artery right here, that's the ventricle, that is way posterior. So coming back anteriorly to begin with. Now there are few reference points which I would like to stress on. Now if you happen to get a CT scan, now according to the books and the rule which we follow, the protocol which we follow outside in our practice, is that whenever you see a patient with sinus infective etiology, you always go with a CT scan. If you have a patient of inverted papilloma, sinusitis, CRS, nasal polyps, AC, ethmoidal polyps, or any skull base problem, you always go for CT scan. That's the rule, right? But if at all you see at any stage that there is an MR orbital invasion or your intracranial invasion has happened, we directly go with CT. Extra, we go for MRI scan. But in certain cases, if CT scan is not possible or is somehow contraindicated for some reason, or if CT scan center is not available nearby and you happen to have only an MRI scan, like in this case for me, I got only the MRI scan. I had no time to get the CT scan done because that was an emergency case. I had to operate the patient. So only on the basis of MRI, I did the surgery, and so this can happen. So on CT scan, what do we look for? Is the lamina papyracea, right? Because of the bony anatomy. So how can one find lamina papyracea, or as a matter of fact, a bone structure on your MRI? Okay, so first things first, I'm going to show you the bone on MRI. This is the frontal sinus. You go behind, you can see that's the sinus. Okay, so this is the most front part. You can see that's the eyeball, the upper eyelid, basically. That's the left and that's the right. This is the frontal sinus, and this is the interfrontal sinus septum. If you go behind, you can see this is black. So bone on MRI, air on MRI, these two structures will appear as black, jet black. So bone will look jet black, air will look jet black. Now this is all jet black, this is air, this is jet black, this is sinus air, frontal sinus. Now if I zoom this for you and take it below, you can see bright grayish white structure over here. That is not bone, that is basically a sinus mucosa. It is not even secretion or collection, it's sinus mucosa. Okay, this is sinus mucosa, and just above that you can see a faint black line above the mucosa level. That is basically the outer table, that is a bone. So that is basically the frontal bone, and that is the frontal sinus. So this is how you can locate the bone. Coming down again in the same picture, you can see this black structure over here. This is a black column over here, the black line. That is basically the frontonasal process of the maxilla. That is the frontonasal process of the maxilla on the right, and this is on the left. But the same thing you can see over here, that is not bone, but that is the air column inside the nasal cavities. This is the right and that's the left. That's the inferior turbinate, that's the inferior turbinate, and that's the nasal cartilage you can see over there. And that's the nasal bone at the maxillary attachment, the maxillary crest attachment, because this part of the nasal septum will be a cartilage, and that won't be very much appearing as black on MRI. It will be appearing as grayish on MRI because it's a soft tissue, it's a cartilage, a soft tissue. So moving on further up ahead, behind as we are going, this is still the same air column. Now you can see a glimpse of the lamina papyracea coming in the picture, and this is basically the lateral nasal wall over here. That's the lateral nasal wall over here, and that's the faint structure of the lamina papyracea, not clearly seen over here. So we move behind, nothing special or extra on this scan. If we go behind now, there are two main things which we have to see over here is the appearance of the maxillary sinus. Now this is right maxilla, completely clear, full of air. This is a nasal cavity air passage. This is the air passage. This is the inferior turbinate, inferior turbinate. The second thing you can see over here is that the septum on the patient's left is being pushed onto the patient's right. That is the outline. That is the septum outline. And you can still not see black shadow over here because this is still the septal cartilage. And you can see this is the maxillary attachment. That is a black color. That is septal bone. That is the maxillary crest bone. So this is still cartilage, and you can see somewhat of indentation happening over here on towards the right side. This is air column. And now you can actually appreciate the lamina papyracea on the MRI scan. This is the patient's right lamina papyracea. Follow my cursor. You can actually see the fine column of black shadow over here. That is the lamina papyracea right there. Same thing you can see over here. This is the lamina papyracea on the patient's left side, and this structure you can see complete opacification over here. Now, as this is a T1 scan, any secretion will appear as dark gray or light gray. But you can see there are few areas of dark gray and few areas of light gray over here. So the light gray stands for secretion or somewhat of mucoid collection inside. But if it is a dark gray area, it could be area of pus, it could be area of thick, long-standing, thick, tenacious secretion as well. But already I have performed the surgery on this patient. It was full of pus inside. And you can see there's one more point you have to note over here is that in the maxillary sinus, the opening. Now, if you can compare the sinus opening on the right side, it's somewhat medial, somewhat in line with the lamina as well. But if you can see here, it is still somewhat in the line of lamina papyracea, but somewhat because of the excess collection over here, it has somewhat pushed to the lateral side. Because while the surgery I was doing, the opening of the middle meatus was completely lateralized. So you can appreciate that somewhat over here. So this is a proper lamina papyracea on the MRI scan, and that's the lateral bony nasal wall. That's the wall of the maxillary sinus over here. So going behind further again, we can see the same thing. You can actually see light gray border outline, and you can see some dark gray collection inside. This could be pus as well. That's the bony wall, lateral nasal bony wall. That's the air column black. This is also the air column above. You can see that's the skull base over there. You can see the black column right there. That's the skull base. So this is the lamina papyracea. No breach whatsoever so far. So we keep on going behind. Now you can actually start seeing a faint black line over here. That's the nasal bony septum. And if we go behind, you can see actual black line over here. That's the nasal bony septum over there. This one. So this one is actual nasal bony septum. You can see a lot of opacification, collection. That's the nasal bony septum. You can see somewhat of deviation on the right side. That's the skull base intact. There is no dehiscence in the skull base so far. So all this can be read on an MRI scan very clearly without any issue. So even if you don't have a CT scan, which a lot of surgeons think that it is a rule, it's a legal rule to do a CT scan in such cases. But if you still don't have a CT scan, it's completely fine. You can study all that on MRI as well without any doubt. Now, this is a huge opacification over here. You can see some dark collection over here. Now, one more point here which we need to notice is the level of the anterior ethmoidal artery. Now, if we go behind, this is still the anterior ethmoidal skull base. Why? Because this is anterior ethmoids. Why I'm saying so? Because you can just see the slope of the skull base over here. It is oblique in nature. Anterior ethmoidal skull base is oblique and sloping in nature. If I keep on going behind, you can see that as soon as the anterior ethmoids finish, the posterior ethmoid starts and the skull base becomes completely flat and horizontal, and still you cannot see the sphenoid appearing. There is no sphenoid so far. This is the posterior ethmoidal air cell, and if I keep on going behind again, still there is no sphenoid. This is a flat skull base, and this is posterior ethmoidal skull base. Now one step I go behind, and now you can see the sphenoid, and now you can see the bone disappearing right now, and that's the lesser wing of sphenoid, and that later on will come with a greater wing of sphenoid. So this black you can see over here is the lesser wing of sphenoid. This is a skull base basically in continuation. Once this defect comes here, you can see this is a defect over here. There is no bone here anymore, but there is bone here in continuation. That is basically pterion, and this is pterion. This is basically skull base, and this is posterior ethmoids. The moment this disappears, it means this is a lesser wing of sphenoid now, and this is the right and this is the left sphenoid. And you can see this patient is having a huge lateral recess as well. So see how easily you can actually study all the bony details, which you can also easily do on the CT scan. So if you know how to read an MRI scan, there should be no issue with your bony details on the MRI scan. Now coming back to the anterior ethmoidal artery level, it should be almost anterior to the end of the anterior ethmoidal skull base. So somewhere around, if you keep on going behind, this should be the area. You can see an actual convergence over here. You can actually see some kind of convergence. That's the Kennedy nipple sign on CT scan, but on MRI as well you can see this is the superior oblique right here. This is the medial rectus right here, and the confluence, near the confluence, you can see a bony projection. You can see a conical projection, that is the anterior ethmoidal artery, and this is a secretion around that anterior ethmoidal artery, and that is the skull base over here. So you can actually locate the anterior ethmoidal artery as well. But on T1 post contrast, because it's a post contrast, I'll be able to show you the entire course of the anterior ethmoidal artery as well very easily. So this was the skull base. This was the entire opacification over here. And now if you keep your attention, I'm going to show you the exact location of the lamina papyracea breach right there. So I'm just going to zoom this. This is a medial rectus. You can see this is all the collection, the infective material, the pus and the nasal secretion inside. So if you can see, this is the black line, the black shadow. That's the lamina papyracea right there. And on this side, you can see that's the lamina papyracea right there. That's the anterior ethmoidal artery. That's the anterior ethmoidal artery right here. So as you go below, that's the lamina over here. So the anterior ethmoidal artery breaches the lamina, it goes out the lamina, enters and travels along the skull base, enters into the nasal cavity and the skull base over here, and enters eventually in the septum and the dorsum of the nose eventually. So it also supplies intracranially, it goes above superiorly. I also have done a video of the entire course of the anterior ethmoidal artery. You can have a look. So this is the lamina papyracea right here, and this is the lamina right here, and that's the bony continuation of the floor of the orbit. There is no dehiscence in the floor of the orbit. You can actually see that it's continuous. But at this particular area, you can actually see that you cannot see any black shadow over here. That is basically the area of the dehiscence of the lamina papyracea, through which the infective material is trying to enter into the orbital cavity right there, and as a result of which the patient is having a periorbital edema and LPS paresis, that is a levator palpebrae superioris paresis, because of which the patient is having tosses on the left side. Now we all know tosses is because of the paresis or palsy in the third cranial nerve, that is the oculomotor nerve, but the patient's ocular movements were all normal. Also the patient's pupillary reflex was all normal. So it means that only the particular nerve segment supplying the LPS from the superior division of the third cranial nerve was affected, maybe because of the compression near that surrounding area. So if we keep on going behind, so the same thing which we can study on the CT scan, we can do the same thing on an MRI scan. So a lot of people who think that CT scan, without CT scan, this surgery is impossible and not ethical, it is not correct. So basically you need to just know, you need to have knowledge of MRI, and if you are confident as a surgeon, you can definitely perform the surgery as well. So this is basically but I'm not saying that you shouldn't be doing CT scan and just solely depend on the MRI scan. If you have the leisure and the capacity of getting the CT scan done through the patient, and the patient is also willing to get it done, please do the CT scan and study the CT scan as well. But in cases if you do not have a CT scan, you have to depend on the MRI. For that, you need to know the basics of MRI. Okay, so moving on to the next step, we've seen the breach of lamina at this level. The next thing we have to see is that on the MRI scan report, it was mentioned that the medial rectus and the superior oblique, they have undergone myositis. Now, how will you identify that a particular muscle is under inflammation and myositis on just a T1 scan? It is not possible, because I said T1 scan, the muscles look gray, dark gray. Okay, there's one more site of dehiscence you can see over here. The opacification is overlapping the lamina. This is a lamina clear cut. This is the floor of the orbit. That's the lamina clear cut. But this area, you cannot see the bony lamina black shadow. This is somewhat white. This could be somewhat inflammation on the T1 scan, because T1, sorry, not the inflammation. This is basically soft tissue shadow. So this is T1, so the inflammation should be dark. So this is same consistency, same shadow as this one. So this is dark. So this could be inflammation as well. So to know whether a muscle is under inflammation, we have to look for the T1 post-contrast scan, because on T2 as well, the muscle is not going to be appearing as a bright white. So T1 post-contrast scan is the best scan to study the inflammation on the muscles. So in cases of mucormycosis, there was severe orbital involvement. I have done many cases of mucormycosis with orbital involvement, and in all those cases, I've just relied only on the MRI. I've never done CT scans for those patients, never ever. I've just done the MRIs for those patients. Not a single patient I operated with orbital complaints of mucormycosis, I've never done a CT scan for that patient. I've always done an MRI, and on the basis of MRI findings, we have done the surgeries. So same thing applies over here as well. So that's the second side of the breach. And now moving further behind, this is interesting. If I zoom this out, this is a skull base. Now this is a posterior ethmoidal skull base as it is becoming more horizontal and flat. Something interesting you can see over here. Now this is all light gray, you can see somewhat, but this is dark gray. Now this is air in the right ethmoid, but this is definitely some kind of a pus collection which is in very near proximity to the orbital posterior apex area as well. This is a lateral bony wall of the nose, and this is the air column, that's the air column, and that's the bony septum in the midline. So if we keep on going behind, you can see the sphenoid coming up in the picture. So this could be a part of the rostrum of sphenoid as well, but less likely this could be the spine of the nasal bony septum. So that's the skull base. Skull base is completely intact, nothing to worry about in that sector. That's the sphenoid. Beyond this, everything is normal. This particular area is of more interest, and this pocket of pus right here, which is in close proximation to the orbit right there. So this was the coronal T1 scan, Moving on further ahead would be the T2 coronal scan. Now the same coronal scan I'll be showing you for the T2 scan. Now I'm going from the anterior to the posterior part. Now this is T2. Now look for the orbit. You can see bright white, that has to be T2. Now look for the brain, and in the brain look for the ventricle, which is somewhere over here. Yeah. So as you can see, if I zoom this, that's the ventricle, severely bright white. And also another part in the brain which you can look for is all these spaces which get filled up with the CSF. Now this is not a blood vessel, so do not confuse that with a blood vessel. This is basically CSF spaces at the outer part of the brain and the cortex, where you can see all this bright white area. So CSF is bright in T2, and this is the carotid artery you can see over here. Because of the flow void, it appears as black. So going behind again and showing you all the basics of the infection. You can see this is sinus mucosa right there. This is a edematous, or you can say a flared up sinus mucosa in the frontal. Because of the excess water content, it appears as bright white, and this is a sinus cavity. This is the inferior turbinate appearing as bright white inside. That's the lens of the eyeball, that's the aqueous and the vitreous humor. So as we go behind, so any secretion is going to be as bright white. You can see all the secretion on the right side, that is bright white, but on the left it is not bright white, it is still dark to light gray, and this has to be pus. Now these findings are almost similar on T1 and T2 to be of a fungus. Okay, this could be fungus as well, but so always there's a doubt whether it is fungus or infection or just collection or pus inside. So it could be a combination of all those things. So unless and until you go and search with the endoscope inside, you won't be able to be sure that whether it's fungus or not. And the last confirmatory diagnosis is culture and sensitivity. So these features look like mostly fungus and collection of pus, but we have pus in the patient, and the culture also came negative for fungus. It came positive for a lot of bacterial infection, probably Acinetobacter infection. The doctor in microbiology was suggestive of the Acinetobacter infection right there. So you can see that this is a maxilla over here. This is bright white, so this has to be secretion and not pus. If we keep on going behind, we have to locate for the area of the orbit and the involvement of the lamina right there. So nothing of significance right here, same structure, same thing. You can see bright white everywhere, but this is dark gray to light gray, so it has to be pus or fungal. We have to locate the lamina on T2 as well. This is the area of the anterior ethmoidal artery. That's the area of the anterior ethmoidal artery right there. So this is entirely full of infective material. So while operation, you have to be very careful, because if you injure the anterior ethmoidal artery, the patient will definitely have a retraction inside the orbit and may give orbital blindness within few minutes. So going on further behind, you can still see the hypertrophied sinus mucosa right there, which is bright white in T2 scan. You can see the posterior part of the orbit, bright white everywhere, and this is the collection or the infective material right here. This is the sinus mucosa. This is the posterior ethmoidal group of air cells. That's the skull base, completely intact. Same thing which we studied on the T1 scan. Same thing on T2 again we are seeing, but everything is white here right now, and little bit of dark gray area in between. You can see that is all infective material. That's the temporal lobe. That's the uncus of the temporal lobe. That's the brain, middle cranial fossa. This is still basically the anterior cranial fossa, to be honest, because we are still in the posterior and the anterior ethmoids group. This is the anterior cranial fossa. Once we cross the sphenoid posterior wall, enter in the pituitary, we enter the middle cranial fossa. So the sphenoid sinus is also be considered as a part of the anterior cranial fossa. So there we go. Still behind, nothing as of interesting. This is a lateral recess in the patient. Okay, so this is all for that T2 scan. Now we can go for the axial. This is basically again T2 scan. You can see in T2 scan this is the lateral rectus, medial rectus, optic nerve. Now why is axial scan of more importance? Because the axial scan shows the entire lamina papyracea as a whole structure. Now if you can see, if you can concentrate on this scan, particular scan over here, this is the area of the breach of the lamina papyracea right there. So if you can see on the left side, this is the eyeball, that's the lens, that's the optic nerve, medial rectus, lateral rectus. If you can remember on T1 scan, this entire thing was bright, right? The fat, the orbital contents was super bright. But the same thing on T2 is less bright. Okay, so that is regarding the fat. Now this is a black structure you can see over here. That black structure is the lamina papyracea. Go behind, this is a black structure, that's lamina papyracea. This is lamina papyracea. But somewhere around here you cannot see that black structure of the bone. So this is a particular area where there could be a presence of dehiscence in the lamina papyracea, and if you see on the opposite side, it's completely intact. There is no breach whatsoever. So this is how we can see on the axial scan, on T2, on MRI, the level of breach of the lamina papyracea. Going behind, you can see something like this. Now there's always been a doubt for me whether this structure is ophthalmic artery or a kind of a superior oblique muscle or the inferior oblique muscle, because now we can see the structure. We're going down and we are going on the brain. So this is basically superiorly. So we are coming from below. Now we are coming from, this is from brain, we are coming above. You can see the structure over here. So this is a structure which is mostly resembling the muscle area, but it has the same course as that of the ophthalmic artery. So it could be a muscle, it could be a superior oblique muscle. It could be a superior oblique muscle because it's going laterally above to get attached here. So it could be a muscle as well. But on T1 post contrast, I can show you the course of the ophthalmic artery and the anterior ethmoidal artery as well. So this is all about the T2 on the scan, the area of the breach. What else? This is all the secretions, which is T2 bright. This is the area of the breach. Now if you pay close attention, if you can compare the medial rectus on the affected side with the medial rectus on the normal side, you can see somewhat of area of bright white area showing the presence of inflammation, because inflammation is bright white on T2, that is light bright, and dark on T1, right? So this area, you can see area of inflammation somewhat, so that the medial rectus has undergone myositis, but that is well more prominent on the T1 post contrast scan. So moving on to the other scan, which is yet another axial scan. This is normal T1. This is normal T1 scan, nothing significant over here. You can see the excess bright white orbital fat in the contents. Moving on to the further ahead scan, this is coronal. Now I need to show you a T1 post contrast scan. This is a post contrast, but a better one I have is this one. Yeah. So this is a T1 post contrast scan. Now this is why T1, because this is dark, but why post contrast? Because I'm going to show you. Now the easy way to locate whether it is post contrast or not in T1 is two locations. The very first location should be your brain, the patient's brain. If you enhance and zoom on the brain, you can see tiny blood vessels everywhere in the brain as white spots. You can see those white spots over here. These are all the blood vessels tiny blood vessels over here. You can see the blood vessel spots. These are all the blood vessels in which the contrast has been taken up, okay, and in which the flow of the vessel is kind of less as compared to the carotid, because if you can see, this is a carotid artery over here, still has a flow void, because these are high flow velocity vessels in which the contrast will not be picked up, but it will be picked up in very small vessels in which the flow is very slow and less as compared to all these. So these vessels, these huge vessels, will have flow void, but the small vessels will not. So the small vessels will show a lot of contrast. You can see that is first location, and the second location is to always look for the muscles everywhere. So you can go and look for the pterygoid muscles. You can see all these muscles over here. They appear as bright white. And the most important location is the extraocular muscles. If you can see, these extraocular muscles appear as bright white. They appear as bright white, and I can actually show you the anterior ethmoidal artery as well over here. This is basically an artery which you can see running around the skull base over here, and this is the anterior ethmoidal artery. This is the anterior ethmoidal skull base. That's the anterior ethmoidal artery with the mucosa mesentery showing a bright white spot. As we keep, this is the anterior ethmoidal. This is a particular vessel which we can see going medially from the lateral. This is the orbit. This is roughly the level of the anterior ethmoidal artery on the right, and this is on the left. So this has to be the anterior ethmoidal artery level. If we go behind, we can see this is a posterior ethmoids right now, and you can see the posterior ethmoidal artery as well somewhere around here. This is a posterior ethmoidal artery. If we go behind, you can see that this is a mucosa of the skull base, and this is a sphenoid now, and that's the pituitary area, cavernous sinus, ventricles, the sylvian fissure, that's the middle cerebral artery, that's the anterior cerebral artery, that's the division of the ICA in the MCA and the ACA, and so on. So basically we need to see the lamina, the status of the level of the anterior ethmoidal artery, the skull base dehiscence present or not, the consistency of the collection and the infective material, and any sort of collection in the intraorbital cavity, intracoronal or extracoronal. So the intracoronal is much better studied on the axial section. So the muscle, so if you can see the muscle on the left side, which is the affected side, I can just zoom that for you. This is the muscle on the left side, you can see, and the muscle on the right side. This is a medial rectus. This is a medial rectus. The medial rectus over here, if you can see, is kind of swollen and boggy and more white as compared to the one on the right side, which is very small in size. This shows that the medial rectus has undergone swelling, but not so severe enough because the patient's extraocular movements are completely normal. Okay. Now, the moment we see superior rectus, this is superior rectus muscle over here. Exactly above the superior rectus over here runs the levator palpebrae superioris in the most anterior part. You can see this is the superior rectus muscle. This is a medial rectus. That's the ophthalmic artery right there. This is the ophthalmic artery which comes from as a branch from the internal carotid artery on the lateral aspect. It runs along and under the optic nerve, and then it goes superior to the optic nerve from lateral to medial, and then travels superior to the optic nerve medially. And you can see this is the optic nerve. In the anterior part, it travels superiorly and medially. So this is the anterior part because this is the anterior ethmoids, and this is the ophthalmic artery. You can see right there, post contrast T1 ophthalmic artery. So that is the ophthalmic artery, and sometimes you can actually see the ophthalmic artery giving a branch. You can see a branching of happening over here, and it becomes the anterior ethmoidal artery, and sometimes you can actually see the posterior ethmoidal artery branching also being given. But this is a 5 mm or 3 mm cut, so this is not possible to be visible on this. So you always ask for a 1 to 2 mm section on MRI as well, if possible. So all these structures can be studied on an MRI scan, which is completely useful. The same thing you can do on the CT scan as well. So this is what you have to know in case of an MRI scan. So we've done the T1, the T2, the post-contrast T1, the level, the basics of MRI, what you can see in T1 and T2. So in the next video, I'm also going to show the course of the third cranial nerve, that's the oculomotor nerve. Now we all know that the, if I can show you the ophthalmic muscles, this is a medial rectus, that is a superior oblique. Now the SO4, that is the trochlear nerve, and the lateral rectus, which is the this is the lateral rectus over here. This is LR6, which is the abducens nerve. See, the superior, the oculomotor nerve has got two divisions: the superior division and the inferior division. Okay, the superior division supplies the LPS, that is the levator palpebrae superioris, which is roughly over here in the most anterior part of the eyelid. You can actually see the muscle over here. This, I think this is supposed to be the LPS. That has to be the LPS somewhere around, not clearly seen, but this should be LPS somewhere. The entire upper eyelid is supplied by the LPS elevation, and superior division supplies the LPS and the superior rectus. So superior rectus and the muscle above is the LPS, is supplied by the superior division of the third cranial nerve, and the medial rectus and the inferior rectus is supplied by the inferior division of the oculomotor nerve. So there are two heads, superior head and the inferior head, and they individually supply these two different sets of muscles. You can also see different vessels over here and different nerve, I think they are the vessels, components of the orbit. So all this can be studied on the MRI scan. So next video I'll be showing the course of the oculomotor nerve, and in the next video to that I'll be showing the surgery of this patient, where I've done the full house fess on the left side, where a lot of pus has come out. Around 40-45 ml of pus has been drained. There was a breach in the lamina in the medial part, as I showed on the MRI here, and also I've performed complete orbital decompression on that patient. The patient has resumed the activity of the elevation of the eyelid immediately within 10 to 15 hours of surgery, and the swelling on the orbit has completely gone down. So I hope you gained knowledge about the MRI. If you have any doubts on this video, kindly message or comment on the section below, or you can reach out to me on my Instagram, Facebook, or YouTube page. Thank you so much.